To further enhance our basic knowledge of an ECG, we have next session chaired by Dr. C. B. Patil, Professor and Head of Department of Cardiology of St. John's, Bangalore. Dr. A. V. Shetty, Retired Professor of Medicine, KMC, Bangalore. Dr. Ravindra Reddy, Professor of Medicine at Pratima Institute. I request you to take your seats. I now invite the speaker for this session, Dr. Ketan Mehta, onto the dais to speak on misleading recordings, artifacts in ECG, how to recognize it. I kindly request the chairpersons to introduce Dr. Ketan Mehta.
Good morning. I think after Jayaprakash's speech how to interpret an ECG in a rapid way, let us see what is sometimes looks like abnormal, that is artifacts, and these may be due to muscle tremors, hand movements, loose electrodes, cable problems, electromagnetic interference. So many things are there which can mimic like an abnormalities, and sometimes junior doctors may mistake it for some arrhythmias. People have given shocks also in such conditions, thinking that it could be an atrial fibrillation or a PT or these things. So let us just learn from Dr. Ketan Mehta what are all the artifacts which you can see and who should try to. And Dr. Ketan Mehta is working in Asian Heart Institute and also Raheja Fortis Hospital and Balabhai Nanavati Hospital, 7-inch Hospital at Bombay. He is Honorary Joint Secretary of ICP and Joint Secretary of ISE and NSPR, that is a preventive cardiology this thing, and is a trust board member of MMA, HSI, MMA, and he is also a organizing secretary of Diamond ISECON 2005. With this little introduction, I request him to speak.
Respected chairperson, my senior colleagues, and ladies and gentlemen, it's indeed a pleasure to be here at the MIDTERM ISECON, and I'm going to talk on artifacts in ECG, how to recognize them. You know, it is really an honor when speaking in front of none other than Professor Dr. Martin Green, who is over here. Sir, it is indeed an honor to speak on that. As Dr. Jayaprakash has rightly said, you know, the first bedside diagnosis, you are going to identify what is normal and what is abnormal. So is this a normal ECG or is this an abnormal? Can I have the trace? Is this a normal or an abnormal? Now once you have picked up abnormal ECG, you need to find out whether are you dealing with a false positivity, because that's very important. Once you're detected there is some abnormality, is this true abnormality or is a false positive? So you know, when you take any ECG diagnosis, it is valid only if electrodes are placed in correct anatomic locations, lead wires are attached to appropriate leads, because sometimes it may happen you have connected the 4 electrodes and so often in hurry that ECG technician, staff nurse connect one electrode to the another leads, and then you know it becomes a totally mismatched. The recording has to be of a good technical quality with a proper filtering and absence of extraneous electrical noises. Then you can have a good ECG recording. Now especially it is important when you are going to have a serial ECG interpretation, because the consistent technique which is important, electrodes has to be in the same location, especially when you are putting on a chest leads, you know, from V1 to V6, and if the position is changing little bit here, you will have a different tracing and people will compare yesterday's ECGs with today's ECGs, and then we will feel the difference. So often in the institutes now, they mark out the position that this is where, okay, you are going to put a V1, V2, V3 to V6, and so that same position the chest electrodes are placed subsequently. Patient's body in same position, because sometimes you know patients is acquiring is orthopnic, you know, taking a ECG, again it will make a variation. So you need to see whether each ECG is taken in the same position, then only you can compare supine versus, you know, propped up, you may have some variation. And of course using the same lead configuration. Now when we talk of artifacts in ECG, they are classified that artifacts which can arise from internal or external sources, internal which is physiological and external which are non-physiological. Now let's see what are those artifacts which is internal, what we talk of physiological, which is could be due to muscular activity, which of course allows electronic filtration. There are small spikes, we will see the ECGs. Then it could be due to patient's motion. So it does not allow electronic filtration, especially epidermal stretching, which will produce this type of tracings. And of course, the tremor induced, especially patients who is having tremors due to whatever reasons, you will have those artifacts. Now, if you see, this is a classical ECG of movement artifacts. You can see that, can I have a pointer? You can see the ECG which has been shown with the normal QRST complexes, and suddenly there are things are happening. So you might wondering, is it arrhythmias or anything? But you know that, earlier and the following that complex, you have got a normal PQRST complexes. So this is the movement artifacts which has come up over there. Then, of course, in Parkinson's patient, so often Parkinson patient does not mean that they cannot have any cardiac abnormalities. They get admitted to, comes to emergency room or comes to casualty and has got, increased movement at that time. Parkinson is uncontrolled, and you will see such arrhythmia. Now, again, you need to identify that this patient is in the sinus rhythm, and if you pick up that this patient does not have arrhythmias, it is because of his uncontrolled Parkinsonism he is having those arrhythmias with. Then sometimes patients having rigors, coming to the hypotension, coming to emergency room, and you are obviously, as a standard protocol, you take all the investigations. So this is of course, due to somatic muscle tremors, which is coming in the multiple leads, you will see all across most of the leads, you will have those artifacts, small spikes coming up. And you know that these are definitely the artifacts which are there due to the somatic muscle tremors. Now, talking about the external causes, that is, you can have due to electromagnetic interference, which is the most common thing. So often, even when you are traveling in a car, and especially the radio is on and your mobile is coming, you will get that vibrations from the radio itself. That is nothing but your disturbance due to electromagnetic waves. So power in the electrical disturbances or light fixtures, electrocautery, which is being used because especially patient is in ICU, nearby places, so many other gadgets are being used. Electrical devices in the room, then radio frequency based commercials like mobile phone products, as I was just mentioning, this will produce artifacts in the ECG, maybe in the actual graphics or also on the recordings which has been done on a monitor. Then cable and electrode malfunction. This is again very important. When you have a nice recipe to be, you know that you're going to have a nice pasta or a pizza, it tastes good, but then what is more important is the person who is preparing. And I'm sure the ladies will know, your husband might complain that today it is not good. So it is the cook who is preparing is very important. Similarly, the ECG, the person who is taking the ECG has a pivotal role in delivering that and can give you the right picture. So you have a insufficient electrode gel, which is very important. Sometimes too excessive or too less, of course, that will be giving an erroneous reading. Misplaced leads, as I already mentioned, inappropriate filter settings, which is their broken wires, half wires it is broken, loose connection, and of course accumulation of static energy. This will produce this. Then medical equipments in operation, when patient is in OT or in ICU, the various equipments, as I was mentioning, can also affect the ECG monitoring system, especially electrodes, leads, amplifiers, and filters. Now, this is the electrical interference from a nearby electrical appliance which has been kept. A typical example of 100 Hz background distortion from a fluorescent light. You may feel what is there, that is nearby happening, but that itself can be confused. Can you see? It can be confused so much like whether it is a atrial fibrillation or what. So you need to see that this is something which is happening that is not actual pathological. Another example of an artifact which is caused by electrical appliance, the rhythm is regular. Now, if you see the strip over here shows the QRS complexes, but in between there are complexes coming like this, and you might feel, is this pathological complexes? No, these are artifacts. So here you know that these are all complexes which are coming at regular intervals, but these are nothing but artifacts which are coming on that. Now, let's come to the technical problems, which is, of course, where we know the person who is behind the ECG machine or person who is taking the ECG is very important. AC mains interference, which I already mentioned, you have most of the leads showing those small spikes. Wandering baseline. Now, if you see, Now see how the baseline is moving over here. Now this is wandering baseline. It is again, you know, it is artifact. You are not talking of any arrhythmias or anything. Now wandering baseline is nothing but the cables moving during the recording. You place the cables, and you know those cables are long wires, and it is moving even while the recording is, I mean tracing is being recorded. Patient movement, of course it will cause the movement of the cables. Dirty lead wires, electrodes not been cleaned regularly, because that is required. Sometimes those ECG jellies which stick to the electrodes, and then same can produce such things also. And of course the loose electrodes, sometimes the staff has not properly attached to the cable, I mean the cables. So all these things can produce such artifacts. Now baseline drift, you know, you see such recording, and especially when you know what is happening, you wonder why this ECG is going like this and up. Now if you see, of course it is normal complexes which are there, but this happens especially when there is a change of lead, especially in certain ECG machines, when you take a long lead 2 and then suddenly you change over to another lead. For initially you might have such type of baseline drift, or especially it occurs when the patient has been given shock and subsequently reverts. You can have such a drift which is happening in the baseline. Now this is an ECG. If you see suddenly, you know, first thing you might wonder, oh, is it what the earlier speaker has already mentioned? You first diagnose whether it's normal or abnormal. Oh no, you feel this is abnormal. Then the next question is this truly abnormal or a false positive abnormalities? And obviously you can see this is not a ECG of atrial fibrillation flutter, but there are a lot of artifacts which are coming up over here. Now when you see these artifacts versus a true arrhythmia, you need to differentiate it. And it should not happen that you label this anyone as an artifacts and they turn out to be a real arrhythmia also. So obviously the morphology is important, but there is been incidences, what sir has already mentioned, that at times people have received a shock in ICU unit, seeing the certain ECGs over the scope, and has been given. I remember one incident, and one of the residents in a hospital is just sees on a scope some fibrillatory waves and suddenly asks for a sister, get the defib, and then the other doctor luckily happens to be there and sees, oh, the patient is Helen Harty. So he just sees the monitor without realizing the patient is Helen Harty sitting over there. This could be artifact. So another incidence is when happens, now you have got a computer synthesized rhythm is there. Now if you see such ECG, first instance you will start thinking, oh, there is a broad complex tachycardia is there. You wonder what is happening. But if you see the raw rhythm at the base, what is happening? There are isolated PVCs which are coming, and what has happened? There is a computer synthesized rhythm which is there, which is generating and giving an impulse image that you have got a broad complex tachycardia. So it's not broad complex tachycardia. If you see the raw ECG, we can diagnose that these are not this thing. So there are certain points I would like to tell in artifacts is differentiating from ECG the artifacts versus the real disease. Once you have absence of symptoms or hemodynamic variation during the event, person is not having any complaints, no palpitation, no chest discomfort, no breathlessness, his blood pressure is well maintained, he is unlikely to have a real or pathological problem. The normal ventricular complex is appearing during the dysrhythmic beats. You have to see in between whether there is a normal complex is appearing. Then of course this is a more likely a normal variant on that. Then association with body movement, you need to see how the body is, what the patient is doing at that time. Instability of baseline tracing during and immediately following the alleged arrhythmia. Again, that will give a clue. And synchronous visible notching consistent with the underlying ventricular rhythm, which is marching through the pseudo arrhythmia. Now what we call those as pseudo arrhythmias, which are not actual arrhythmias, which will be do. Now there is a nice article Huang et al. Has described there are 3 signs differentiating artifact from ventricular arrhythmia. First one you said is the sinus sign. What does it say? One of the frontal leads, either 1, 2 and 3 may present with sinus rhythm which shows normal P, QRS and T waves. The reason given is that one of the upper limbs may be free of tremor. Second is a spike sign, that is presence of regular or irregular tiny spikes among wide QRS complexes. Those are various spikes we have seen in the previous ECGs which were there. And the third one is the notch sign, that is notches superimposed in the wide QRS like complex artifacts and coinciding with the cycle length. So cycle length remains the same when the sider's rhythm was recorded, and these are the three signs which can be seen in an artifacts also. Now coming to briefly about the lead misplacement, again commonly observed especially in ICUs, in emergency room. You know how the leads are placed, you are aware of them, and how the leads are recorded. Now what happens, you need to identify and see, at least you can able to pick up, okay, no, this has been misplaced, or these are the leads which has been wrongly connected. Now remember, if the complex in lead 1 including the P wave appears upside down, the left and right arm leads are reversed provided the precordial leads are not suggestive of mirror image dextrocardia. I am going to come, because that's going to be a differential, whether it is a RA LA switchover or it's a mirror image dextrocardia. Now here what happens in the lead 1, once it is inverted, obviously you know, and this is the graphic recording, you will get it in lead 1, you will have everything negative, PQRST negative, which you are not going to get it otherwise. So here RALA is reversed, but only thing is you need to differentiate whether it is a true mirror image dextrocardia. Now how do you do that? Once you have got a lead 1 which is showing all negative complexes, you need to look for whether it is RALA lead or whether it is a dextrocardia. You need to look at the precordial leads. See what happens in the normal person, otherwise there has been progressive increase of the R wave amplitude V1 to V6, and what happens in mirror image dextrocardia, it will be the reverse way. In V6 will be the smallest R wave which is then, and V1 will have definitely tall R wave, so you will able to differentiate. Similarly, you can have a reversal of LA and LL also, and where you have a negative complexes in lead 3, so all the complexes in lead 3 will be negative. Coming to sometimes, staff is totally new and will have interchange LA, LL and RA, all three has been interchanged, and you will have lead 1, lead 2, lead 3, all three totally negative. So all PQRST complexes are negative in lead 1, lead 2 and lead 3, which is of course in extreme cases. Now remember, if one of the standard limb leads is almost a straight line, that means the RL has been switched to one of the other limb leads. Now if you get a straight line like here in lead 2, which has been straight line, when RA and RL has been interchanged. Now again you can further find out about what has been changed. Like in the augmented unipolar limb leads, the leads showing all negative deflections including the P wave, that is PQRST, all are negative, indicates whether the right arm is involved or not. If such a complex is seen in AVR, right, so you know that AVR we get all those complexes negative, that means the RA is not involved, because if RA is involved you will not get that negative. So and if it is seen in AVL, RA is switched with LA, and if it is seen in AVF, RA is switched with LL. So this is how, example, if you see this patient with a normal sinus rhythm and look at this AVR, it is, of course it has been upright, so the RA has been switched over here. Now misconnections about precordial leads. Your earlier ECG machines were having a single precordial bulb. So you're going to put every time, go on changing from V1 to V2 to V3, V4, V5, V6, and now you got a newer machines where you have got 6 different precordial electrodes and you go on placing it. Sometimes what happens, the sister may place it V2 over V3 or V3 over V6. It is difficult to diagnose from ECG per se, unless you have got a previous ECG which is available for recording, so you know that this is something wrong. So that is very difficult to identify. So there are more likely of errors when you have got multiple precordial electrodes which are available. Other common artifacts like electrodes on the torso, placement of electrodes on torso may lead to change in vectors and produce pseudo Q waves and pseudo ST segment elevation, which can mimic like a myocardial infarction. Telemetry interference, which comes superimposition of telemetry electrodes over the EKG electrodes or vice versa. You have got 2 devices which has been connected together, and of course which may cause ST segment deviation due to electromagnetic force. Loose wires, as I already mentioned. Now tall T waves, a tall T wave may be mistaken for an R wave. This sometimes happens, and the digital heart rate would be higher, because what they will calculate is presume that it is a R wave and will calculate as double the actual. Sometimes, you know, your cell interpretation ECG comes and they go on calculating that. So you need to be, don't rely blindly on that. You need to see yourself on that. And of course, the motion artifact already mentioned, lead placement I have already mentioned. So artifacts removal in ECG signals, what should be done? Perform good skin preparation, check the electrodes, check the electrode gel to make sure it is fresh and moist, check for AC interference, electrical wires in the walls, ceiling or floor, and of course move the examination table away from the wall. Sometimes, you know, if it is touching the wall, then it can cause sometimes disturbance also. Verify the filter settings in the device. Finally, if the tracings are still showing artifact, make sure that the following filters are turned on, that is muscle filter, AC filter and wandering baseline filter. Make sure that the patient is warm, relaxed and does not move or speak, especially while taking ECG. That is so often patient is talking to the doctors or anything. It should not be. Then patient should be totally relaxed. Do not place electrodes over the bone, irradiated skin, areas where there is a lot of muscle movement, and of course where there are previous incisions are there. So to summarize, attention to basic principles such as proper electrode placement and lead connections required during EKG monitoring. Well-designed and maintained EKG measurement devices can withstand routine internal or external electrical and motion-related disturbances, which I had just mentioned. However, it is not always possible to eliminate artifacts completely. So it is essential for the physicians to keep a high vigilance and interpret EKG, keeping artifacts in the differential diagnosis, and should pick up the false positive pathology or false positive abnormalities from that particular ECG. Thank you for your patient hearing.
Thank you, Dr. Mehta. Yes, I think we will answer some questions. No?
Yes, sir.
Enough time? Yes, go ahead. Ask the question.
Most of the time,
so first is, of course, you can have the, at that time, if you can't have a 12 lead ECGs, first you are interested in knowing two components, whether he is having arrhythmias, and second is of course the ongoing ischemic infarct. Now for arrhythmias, even if you can take a one single lead, you know, because you may, it will be very difficult to have of course the chest leads at that time, precordial leads. So arrhythmias you can definitely pick up if you have one single long lead too. But for infarct and ischemic event, you need to have, so you will get with disturbances, but of course you will have to see, sometimes the hemodynamic instability is there where you need to take, you know, patient is so restless, he will not allow you to take ECGs. You have no option but to stabilize at the earliest and take whenever he is stable enough to at least take the ECGs. But at least arrhythmias can be life-threatening, which you need to pick up. The second option is put the patients on a cardioscope monitor. You can pick up from there at least on that, where and then can definitely treat accordingly. So ideal aim would be to stabilize him and take at the ECG. But this is a practical problem which I am sure all of us faces in day to day. I agree with that.
Any of the technicians, when they take the ECG, when they apply the gel, I have seen they just take they squeeze the gel tube right across. You know, it's like one long, like on your toothpaste, and then they have taken the ECG. I was very surprised. Does that actually produce any, you know, it will alter the nature of conduction?
Correct. What you said is absolutely right. Too little or too excess jelly will also produce disturbances also, and ideally, especially when you are taking a precordial leads, whatever the required amount of ECG gel has to be placed at localized position rather than drawing a line from, you know, V1 to V6. So ideally that's why V1 to V6, it has to be placed in a proper position. What happens, this is commonly in hospital setting or maybe in ICU, where, you know, they don't differentiate whether the common jelly which is used for defibrillating or giving a shock, where they are just applying jelly over there, and same thing principle they applies for the ECG, but definitely that can also produce the disturbance also. So ideally it should be at individual position rather than as a continuous.
Can you use the plain water instead of gel?
Can you?
It is a good conductor heat and electric. Plain water instead of jelly.
Plain water. So ECG, because plain water will not stay at particular position, and secondly you will have a difficult.
Those are not having ears and all, it will work. That leads will stick.
So gel standard the
If
jelly.
ears are there on the body, we can use jelly. Otherwise, plain water is better. Sometimes I have observed a reaction for jelly.
Yeah, that is known. Even the cutaneous reactions are known with the ECG jellies, and there are some patients who develop reactions. That is known. But obviously, it may not be possible in each and every patient to have, because especially the patient has got a hairy. How many of us really see that ideally the shaving should be done over the chest before taking a proper 12-lead ECGs, which for all practical purpose does not become. Though it has been mentioned as a standard recommendation, it is not possible.
Yeah, I think I just wanted to ask that question, because in some of the textbooks it is told tap water, even toothpaste jelly. I mean, in Marriott's textbook, he has told even sometimes you can use toothpaste jelly. I mean, is it true that we should have jelly only, or as he asked, I mean, anything?
Yeah, jelly, because the conduction would be the same whether it is. The only thing is from comfort point of view or hygienic point of view or even the patient's point of view, we may not use that way, but that will also have the same electrical conduction from whether you take any sorts of jelly. And that's why even people use it. Ideally, there have been separate jellies which are there for defibrillator also, and the separate jellies for ECG machines also. But people are always interchanging that.
Yes, the ideal thing is to use the jelly, but any liquid is all right. Water, tap water or saline or whatever is available. And sometimes a certain patient you don't require it. You just put the electrode in that and you take that. That depends on your the emergency situation that you run out of jelly, etc. So I thank you, Dr. Mehta, for that presentation. And one thing you mentioned is in most of these machines you have a speed that is 25 millimeters and 50 millimeters. Occasionally the ECG girl presses the 50 millimeter speed and takes the ECG, and many times diagnoses sinus bradycardia because the rate comes as half. That's one thing I think that I have experienced sometimes. Many times patient referred for severe bradycardia, and you find that actually it is a ECG paper has run in double speed because there are two controls on the machine, 25 millimeters and 50 millimeters.
So that's why, sir, good cook is required for a good recipe. Thank you so much, sir.
Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. I now request Dr. B Patil to hand over a token of appreciation to the speaker, Dr. Ketan Mehta. I request Dr. Ketan Mehta to hand over the certificate.